Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology to combine mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind! Pune-based Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start Phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind! Pune-based Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start Phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind! Pune-based Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start Phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind!
I think we can go live.
Yes, sir. We are live now. Over to Dr. Arvind.
Yeah. Good evening, colleagues. I'm Dr. Arvind. On behalf of iNDUS BMT Group and MCure Pharma, I would like to welcome each one of you for today's academic session to provide you updates on transplant and cellular therapy. It's our endeavor to bring the cutting-edge scientific programs to help you manage your patients in a better way and provide the scientific updates. For today's live webinar series, we have none other than Dr. Vikram Matthews sir as our program chairperson. And it's my privilege and honor to invite Dr. Vikram Matthews sir for today's live webinar series. He doesn't need any introduction. He is the Associate Director, Professor of Hematology, Department of Hematology at Christian Medical College, Vellore. With this introduction, now I invite Professor Vikram Matthews sir and hand over the session to him. Over to you, sir, and thank you so much for joining us today.
Thank you, Dr. Arvind, and thank you to MCure for helping us get this going together. I want to thank upfront the speakers who are coming early morning, practically getting out of their beds to do this talks. Thank you so much for taking the time off, much appreciated. I'll hand it over to Dr. Rakesh Goyal, who's the president of iNDUS BMT, to take the session forward. Over to you, Rakesh.
Yeah, thanks very much, Dr. Matthews. And we'll straight away go to work. So, good evening, everyone, and welcome to this iNDUS BMT update on transplant and cellular therapy. A live webinar series. My name is Rakesh Goyal, and I'm currently serving as president of the iNDUS BMT group. This group was founded in 2013, and it includes transplant and cellular therapy experts of Indian and South Asian origin, and is focused on promoting educational activities. We have an exciting agenda for this evening. To the delegates and attendees, you are all on mute. However, you can ask questions using the chat function. We'll get to them during the question and answer audience discussion part. At this time, I would like to introduce the moderators and the speakers. I'm trying to share the screen here. So here we go. So our moderators are Dr. Pankaj Malhotra and Dr. Sharad Damodar. Dr. Malhotra is professor in charge of clinical hematology at PGI Chandigarh, and Dr. Sharad Damodar is hematologist and transplant physician at Majumdar Shah Medical Center, Narayana Multispeciality Hospital, Bengaluru. I'd like to thank both of our moderators and welcome. We have a August slate of speakers. Dr. Parmeswaran Hari is Armand J. Quick, William F. Stapp Professor of Hematology. Hari also serves as Chief of Division of Hematology Oncology at Medical College of Wisconsin, Milwaukee, United States. He's also serving as Secretary of American Society of Transplantation and Cellular Therapy. Our other speaker is none other than Dr. Sergio Geralt. Dr. Geralt is currently the Deputy Division Head of Heme Malignancies. He is Melvin Berlin Family Chair in Myeloma Research at Memorial Sloan Kettering Cancer Center, New York, New York. He's Professor of Medicine at Weill Cornell Medical College and past president of ASBMT, also now known as ASTCT. So without further ado, I would hand over the stage to Dr. Hari Parmeswaran for his first presentation, which is an update on lymphomas. Dr. Parmeswaran. Dr. Hari, are you able to share the screen?
Stop sharing your screen, Rakesh.
Okay. Hari, you should be able to do it now.
Yes, thank you. Welcome, everybody. So good evening to people listening in from India, and good morning to America. So in the next 25 minutes, I will give a quick update on the state of cellular therapies for lymphoma. As you all know, the two major diseases for which we do both auto and allo transplants and now cellular therapy with CAR T cells are diffuse large B-cell lymphoma and mantle cell lymphoma. For follicular lymphoma, the transplant activity has gone down quite dramatically, prompted primarily by the new drugs that have come through in the last decade. We'll then talk a little bit about the selected abstracts from the TCT meetings that now seem so far away. It was in February, not that long ago. That was the last major travel that we all had. After that, it's all been shut down. So that's how we will go about it. Going to the next slide. Let me see if I can go. Yeah. So we all know that the primary basis by which we do the autologous transplant for relapsed diffuse large B-cell stands on the PARMA study, which was now published almost 25 years ago. And that's a study that showed that autologous transplantation is the treatment of choice for patients relapsing from diffuse large B-cell lymphoma. Just to remind people, in that study, the conditioning therapy used was what we call BIAC, or BCNU, etoposide, Ara-C, and cyclophosphamide with involved field radiation. The most commonly used transplant conditioning regimen for the same autologous transplant for diffuse large B-cell is these days BEAM, where the cyclophosphamide was switched over to melphalan, 140 milligrams per meter square, and no radiation is used. There is another very popular conditioning regimen that's used in the United States. I don't know how popular it's in India, which is CBV, which is very similar principles. So one of the questions that we continually ask, both Sergio and myself are very, very interested in this question, is can we improve conditioning? Because we have not, this is one area where we don't make much improvement. So the BMT CTN several years ago did a study of Rituxan beam versus Bexar beam. Bexar, as you know, is the radioimmunoconjugated antibody. And there was single agent activity in follicular lymphoma. So we added it to the conditioning, hoping that that would improve outcomes. Unfortunately, it was a negative study. Then we recently analyzed in the CIBMTR beam versus Rituxan beam to see if the Rituxan beam is any better than beam. There again, we could not show any major advantage in autologous transplant for adding stuff to beam. With that in mind, at the TCT meetings this year, this is the memorial group, I think, from showing the variability in AUC when we use melphalan. So the bulk of the conditioning, the last day of beam is melphalan, 140 milligrams per meter square. And in the myeloma literature, both of us, Dr. Geralt and myself, are interested in the variability in melphalan exposure when we give the same weight-based or body surface area-based dosing for melphalan. And here again, as you can see, there's a pretty dramatic difference in the exposure of melphalan. But in this study, probably because limited by numbers, the people who got more than median exposure, the only difference was actually in the toxicity, not really in any survival-based outcomes. So there is more coming in this area, I'm pretty sure, because we are now trying to optimize the amount of melphalan we deliver, just like we have optimized busulfan. It took many, many years for busulfan optimization. This is probably going to happen for melphalan. Now let's go to the change in field. This is a time of major change in what we are going to do in terms of cellular therapy for lymphoma. CAR T cells have now been approved most recently. Within the last week, they were also approved for mantle cell lymphoma. They are already approved for ALL, as you know, in young people, diffuse large in various forms, transformed or primary mediastinal, etc. So these CAR T cells are all the first wave of CAR T cells. The agents approved, again, as you all know, are these ones. They are, based on the Zuma study, the agent that we call Axicell or Yescarta for ease of naming it. This is a retroviral transfused CAR T cell director against CD19. And the co-stimulatory domain is this molecule, CD28. Whereas the earlier one, actually the one that was first published was actually this one, but the approval came a little bit later. It's also known as Kymriah. And this is Tisocell, and the co-stimulatory domain is 41BB. The viral vector that encodes this is a lentiviral vector. And most recently, this is Lisocell, and this is not yet approved, but data were presented at ASTCT meeting, so we'll talk about that. You can see that the progression-free survival rate, or let's look at the overall survival rate. For people with relapsed diffuse large B-cell lymphoma, many of them had prior auto transplant, as you can see. In this population, the overall survival rate at 2 years is about 50% for the one with maximum data, that is the Axicell or Yescarta. For Kymriah, the data is only updated to 1 year, and it's again 50%. For Lisocell, which is also known as the Juno CAR-T, it's about 60% at 1 year. So there's not much difference to choose from between the three agents. There are differences in terms of CRS and other toxicities slightly in actual use. We'll talk about that in a second. If you just look at response rates, it's again in the range of 40 to 50% across the board. But we also need to know that in these studies, how the intent to treat population is not what was always studied. In person science consent, then they have to be enrolled in the study, then they have to collect cells. The cells have to be made into CAR-T cells at a different location, and they will be shipped back. So the median time is anywhere between 4 weeks to 5 weeks, and so in some cases even longer. So that means that not everybody who intended to go on study actually got the cells. There's a huge drop-off in the number of patients who actually received it, despite having the intention or the need to get them. The durability among the CAR-T cells we just saw, but what I want you to look at is the grade 3 and 4 toxicity, which is the right-hand column here. Grade 3 and 4 CRS, which is cytokine release syndrome, which is this major immune-mediated storm that happens in patients who have actively proliferating CAR-T cells in their body, was 18% to 22% across the board. So basically, it's in the 15 to 25% range for all of these agents. And this agent, JCAR017, it is the agent that we saw in the Transplant study. That seems to have a little lower grade 3 and 4 CRS percentage. That's mainly because they modulate the ratio of CD4s and CD8s that are given to the patient. CRES is now known as ICANS, or immune-mediated neurological syndrome. It is the encephalopathy that happens. And again, it goes kind of hand in hand with CRS, but not everybody with CRS gets encephalopathy. And you can also get it after the CRS has subsided. That again is an even worse toxicity because it's sometimes very difficult to get back to normal. There was an analysis presented at ASTCT about the comparison of ZUMA-1 with patients who could not get CAR-T. So remember, all the CAR-T studies are phase 2 studies. The data only applied to patients who actually got the CAR-T cells, not to patients who wanted to go on CAR-T cells. So the comparison group is SCHOLAR-1, which is a SCHOLAR study, which is a retrospective analysis of patients with refractory DLBCL in the pre-CAR-T era. And it was all first published in Blood in 2017. And now that data set remains as a comparison data set for ZUMA-1 and other CAR-T studies. So you can see overall response rates are 72% if you got CAR-Ts, 22% if you got other non-CAR-T standard of care. CR rates 50% versus 7%. 2-year survival rate, we saw 50% for Yescarta in ZUMA-1 versus 12% for SCHOLAR-1. So CAR-Ts have definitely changed the outcome for these patients. And the intent of most patients in ZUMA-1 was to get CAR-T, but many patients did not. If you take those patients, that 50% 2-year overall is going to go down to somewhere in the 25 to 30% range. So the degree difference is actually if you were eligible for CAR-T with refractory DLBCL and if you managed to get it, not for everyone in that setting, because many people actually die in waiting. Some people don't have enough T cells. Some people have manufacturing failure, and all of those need to be taken into consideration. Now let's look at another aspect, CAR-T versus auto transplant, which is where the field is now going. So if you look at the CORAL trial, which is a very informative trial, the primary question was, what is the best salvage therapy? RDHAP versus RGDP, Rituxan GHAP versus GDP. And in that study, one of the things that emerged when analyzed was that the salvage matter in the end, but patients who had prior rituximab-based chemoimmunotherapy induction with CHOP or R-CHOP, for example, if you received Rituxan and you relapsed within 1 year of diagnosis, you actually had a pretty dramatic drop-off. Your prior Rituxan yes patients in the first few months did not actually respond to salvage as well as the people who relapsed more than 1 year after diagnosis. If you relapse more than 1 year after diagnosis, the outcomes was for the same. But if you relapse within a year after diagnosis, after having received R-CHOP, not just CHOP, your salvageability was very low. And most patients actually died. Only 40% of patients actually ended up going to transplant, whereas this drop-off was basically because people could not get to transplant. Now, so then it comes to this question. For a patient who is not responding to salvage, what do you do? And define not responding to salvage. So let's look at a more gray patient. So this is a patient with diffuse large B-cell lymphoma. You can see his PET CT shows a lot of activity. And question is, after salvage, there is clear reduction in activity, but there is definitely residual activity. So this is a sensitive patient. In the olden days, we didn't have anything better to do but auto transplant. We would transplant them. But now we have CAR-T. What are you going to do for this patient? So that's the question. And my colleagues at the CIBMTR tried to answer this question. So they looked at patients who received a first auto transplant, receiving an R-CHOP induction or R-CHOP-like, which means R-EPOCH and things like that. Common conditioning regimens before auto transplant, but sensitive disease. So PR with PET positive, not refractory, mind you. So they were classified as early failure within 1 year or late failure beyond 1 year. So the progression-free survival, if you look at, or the overall survival, it's again goes back to this thing we see. For early chemoimmunotherapy, failure is bad, but even there, we have a long-term progression-free survival of almost 45-50% if you manage to get to auto transplant. Again, this data set is corrupted by the fact that the failure in this early chemoimmunotherapy failure is actually because they don't get to transplant. If they get to transplant, they're going to be okay. And that has been shown by many studies that we have done before. So overall survival, if you didn't have early chemoimmunotherapy failure, is actually pretty good. It's about 65%. So this again indicates that you can actually salvage and possibly cure about 45 to 50% of patients if they can get to a transplant. And that is not particularly different from the CAR-T data that we have seen so far. So here in this area, I think the one thing would be to actually stick to tradition. And unless a randomized study, there are 3 randomized studies going on right now, reads out in favor of one or the other, we stick to what we have already done before. So the questions again remain, CAR-T versus auto for early relapse. So that's the one group we already said are not going to do well. Many people don't get to auto transplant. So maybe we should think about, instead of salvaging them, we should collect T cells early and make the CAR-T so that while they're receiving the first salvage, CAR-Ts can be made. For PET positive sensitive patients that we talked about, and CAR versus allo transplant. So one thing is clear, after CAR-T got approved in 2017 October, the auto transplant activity in the United States has gone down dramatically. So we were doing 1,200 to 1,400 auto transplants a year for lymphoma or diffuse large B-cell lymphoma, and it has dropped by 50% with CAR-T. Here again is CAR-T activity. As you can see, no CAR-T activity until about 2015, and now that's gone up to about 800 cases. So the missing gap is actually made up by the CAR-T and then some. Allo transplant activity for diffuse large B-cell also has dropped down a touch. As you can see, this is the green line, allo transplant activity, and again, concomitant with CAR-T went down. So allo transplant again in diffuse large B-cell lymphoma, these are studies that we have done before. If you have chemosensitive diffuse large B-cell lymphoma, you cure about 25 to 35% of patients. If you have chemorefractory, you still cure about 20% of patients. And most of us these days do reduced intensity conditioning. But a durable control in these patients with relapsed after auto or primary refractory diffuse large B-cell where auto is not indicated is an unmet need. And CAR-T, as you saw, is about 50% if you look at the patients who actually got it. It is about 25 to 35% of patients who need it. So this is some data on the CIBMTR on what has happened. We have not analyzed this for survival yet. So we are looking at about 150 plus CAR-T patients, and most of them are these are post-auto failures. 14 months after auto, they're getting to CAR-T. Allo, most patients are about 20 months after auto. You can see that the number of patients with sensitive disease is much higher for allo. So they're getting salvage and getting allo, whereas for CAR-T, most patients are actually less sensitive, chemosensitive at that point. So we are going to analyze this data, and that'll be there. There is a position statement that came up from the CIBMTR and BMT recently on what is the role of allotransplant in the future. So one of the areas is in regions where CAR T cell is not readily available or readily accessible for patients. Patients who have persistent disease or who are MRD positive or who have a PR after CAR T, those patients are almost always going to relapse. Your PR can improve up to about 3 months, but after that you're still in a PR. You need to consolidate that with something else, and allotransplant is a readily available tool. Actually, in my practice, I would say that in the last 6 months or so, I'm seeing a lot more patients who are Carpi failures. Patients with poor marrow reserve, obviously, who will need more treatment in the future, you can actually fix that problem by a reduced intensity allo. Patients who are getting MDS or some other myeloid disorder, and patients who have manufacturing failure for CAR T, patients who relapse with a CD19 negative clone. So that's one of the important CD19 CAR T. So in relapse refractory BALL, as you can see, with the arrival of CAR T, this question became much more prominent. Should we proceed to allo in patients who actually have a response to CAR T, whether a complete response? And so this consideration is much stronger. This question is actively being debated, and while it looks like in children you may not need to, a lot of adults are getting consolidated with allotransplant in refractory ALL that gets into a CR from CAR T. In BNHL, that question has not been asked so far, or at least been not prominent so far, but these patients have a much significant rate of relapse and progression, and we really need to consider this as an option. But for allo to take over, we need to reduce non-relapse mortality, and that, especially in the post-CAR T world, we really definitely need to reduce that because we are competing against a modality which has very limited non-relapse mortality. So if you look at 4-year non-relapse mortality for various conditionings that we do, the flu MEL 140 stands out, and that is actually one of the conditioning regimens that many people use. And we actually, I do use a lot of MEL in allo conditioning because of my myeloma background, but I nowadays reduce it to flu MEL 100 and flu-cy TBI, flu-bu, flu-cy, all of them have a much lower non-relapse mortality rate in the 15% range. Remember, this is not all transplant related. We cover all non-relapse death as non-relapse mortality. So it's not like, transplant itself is the cause. It could be other things too. But overall survival is actually pretty good for 4-year overall survival for refractory diffuse large B-cell lymphoma transplanted in the real world. This is CIBMTR data. As you can see, you can cure these patients, especially if they have chemosensitive disease at the time of allotransplant. So that makes it very important that if you're thinking about CAR T failures to transplant, don't wait for florid failure. You can do it for PR, you can do it for early relapse, etc. Now let's quickly go to mantle cell lymphoma. So here's a patient with mantle cell lymphoma, stage 4 mantle cell lymphoma, got auto-transplanted in 2016. Then he relapsed 2 years later, started Ibrutinib Failure on trial, and after 18 cycles, he's relapsing again. At this time, he's age 69, ECOG is 1. What would you do next? So as I just said at the beginning, CAR T for allo has just been approved in the United States, and one option would be CAR T. But if you look at poor risk mantle cell mantle cell lymphoma at relapse, 2 years is the cutoff point. If you relapse within 2 years, we call it a 24-month relapse. Median overall survival is only 22 months. For relapse beyond 2 years, it's actually 10 years. So it's a pretty dramatic difference on transplant for mantle cell lymphoma based on when you relapse. The other big time issue is Ibrutinib failure. If you have a BTK inhibitor such as Ibrutinib, and there are a couple of others now, Zanubrutinib, Acalabrutinib, if your median post-relapse overall survival in BTK refractory patients is 5 months, that's actually very dramatically low too. So some of the points is, another important basic point is that allotransplant has really good, meaningful immune effect in mantle cell lymphoma. This is a paper from almost 5 years ago. If you look at allotransplant in CR1, overall survival, there is a clear-cut plateau. This is as definitive of a cure as anything else. But it depends on the time when you do it. If you have late allotransplant after multiple relapses, you're not curing as many patients. The curability goes down by about 20 percentage points. Again, early allotransplant, you have basically a flat line of relapse. The relapse number is about 10% and stays there. Again, with CAR T, as you can see, in mantle cell lymphoma has gone down dramatically. As you can see here, the number of patients getting allo transplanted were about 120 in about 10 years ago, down to about 50 patients per year. And that correlates with the number of agents we are getting. So this new drug, KTX19, which is a Carpi, nowadays the trade name is Tecartus. This was just approved in the United States for mantle cell lymphoma. It's a slightly modified production method in terms of T cell separation and T cell activation using beads and then produced. It's the same construct as the Yescarta kite construct. So this was published in NEJM and presented at ASTCT by Michael Wang from MD Anderson. So they treated about 70 patients, and this is the important thing, 100% BTK inhibitor exposed, 70% BTK inhibitor refractory. As you can see, that's a really bad population. Median overall survival is about 5 months for those patients, and high TP53 mutation rate, Ki67 proliferation index high was 70%, etc. Overall response rate 93% with 67% CR. That's dramatically effective. Grade 3 CRS is about 15%. As we saw, that number is about 15 to 25 for that particular brand of CAR-Ts. Neurological events grade 3 and above, 31%. These are serious events, but again, the non-relapse mortality is actually low. And here is the overall survival and progression-free survival curves. Is again, you can see that the PFS curve is pretty stable after about 14 months, very consistent with the immune effect hypothesis in mantle cell. So you can actually cure people with an immune process. So now comparing these two, allo transplant versus engineered cell therapy, immune effects are about the same. Salvage therapy, we need it in allo. CAR-T, you don't need it. You can just go straight to CAR-T. Long-term overall survival, we are curing about 50% with allo transplant. CAR-T, we don't know long-term because the numbers are quite small. Chronic GVHD is our problem. CRS is their problem. Cost, is much cheaper for allo. CAR-T is much, much more expensive. Standard of care availability is very true for allo, but it's not standard of care across the world for CAR-T. And they're not mutually exclusive. That's the most important point I would like to make. We are not competing against CAR-T. We actually need to consider it as a complementary therapy. So one of the things would be to look at the high-risk features in patients with relapsed mantle cell lymphoma and use targeted therapy. Is there a targeted therapy available? Basically, there are TP53 mutation drugs coming, BTK refractory drugs coming like Loxo. And if none of those are available or studies are not available, consider immune effector cell therapy, either CAR-T or allo transplant. When there is available trial or commercially approved CAR-T in your country, in patients who cannot tolerate an allo, you would consider CAR-T. For allo transplant patients many of these patients have MDS developing. Patients sometimes have clonal hematopoiesis outside of MDS. Patients with P53 mutation, all of them we could consider for allo. And also, this is switchable. You could do an allo and you can do one of these. I have, and I Sergio have done many CAR-Ts in patients who are post-allo. Those patients are typically not taken into trials, but they're excellent population to do a CAR-T after, because what you're getting is donor origin T cells that have been collected from a patient. So basically, it is collected from the recipient, but it's donor origin. Finally, in conclusion, I just would like to say a couple of points. These are some of the abstracts that were presented at TCT. One of this, if you have a prior CD19 targeted drug, does the efficacy of CAR T cells go down? Right now, we don't have data that it does. So there are many CD19 targeting drugs, some in development, some already approved. Blinatumomab is a classic example. We've all done CAR-T in patients who are BLIN failures, and they do respond. So this is for tafasitamab, which is an ADC against CD19. And again, even in the presence of tafasitamab, CAR-T seems to be effective in vitro. These are some of the data on biomarkers of CAR-T success. So CRP levels and angiopoietin are associated with neurotoxicity. So angiopoietin is basically a vascular leak protein, and that seems to be associated with neurotoxicity particularly. This is interesting data for all of us. This is real-world commercial success of CAR-T after approval. This is CIVMTR data looking at CAR-Ts done outside of clinical trials. So out of about 250 patients who were pherased, 2/3 of them got Axicell or Yescarta, 1/3 got Kymriah, which is the Attisocell or the Novartis product with 41BB. This is the CD28. So about 10%, 8 to 10% are dying before the product. day 90 overall response rate was about 50% with 39% CR. So if you do get it, you do respond just like the study says. But this is the population. And again, in this time period, in the real world early access, a lot of people could not get on because of insurance or other reasons in the United States. Tocilizumab use has gone up quite dramatically, but that does not seem to impair the response of CAR-Ts. And about 2/3 of the patients are now getting Toci with the Yescarta product, and slightly less in, actually 13% in Tisocel. Kymriah is slightly less, as we saw in the CRS slides. This again is the CRS and ICANS, which are the major toxicity. So Max Dopp in Germany did the study where they gave preemptive tocilizumab and steroids at grade 1 level. Normally we treated grade 2 or above, and he showed that even when you give it early for both steroids or Toci, the CAR-T AUC does not go down by much. It's just identical, in fact, slightly better for the patients who got early Toci. So this is, again, very refreshing data in that the CRS rates can be brought down by early intervention, and that doesn't seem to improve responses. This is the duration of response curve. Finally, we did mention this agent before, so I'm not going to talk about it. A couple of points. One more point. This is Carpi failure in CLL. So essentially, CLL is an agent, it's a disease which is CD19 positive disease where CAR-Ts have not been as successful as before. And one of the reasons may be that there are these extracellular vesicles, which are exosomes, which are budded off the cell surface. And there is some data emerging that these EVs, or extracellular vesicles, can impair donor CAR-T antigen-specific proliferation and cause T-cell exhaustion. So one of the strategies may be to activate the T-cells using other agents concomitantly given. CAR after CAR, a second infusion of CAR T-cells is something that we have done quite a bit in the United States. It seems like second infusions produced at the time of the first collection are the ones that are being used. A second collection, pheresis, and a second manufacture are almost always failing. Even if you make the product, you don't actually have great responses. That's it. Thank you.
Thanks very much, Dr. Hari. We'll straight go to Dr. Gerald's presentation.
Good morning, everybody, and thank you. Good evening, I should say, for those of you in India, and good morning for those of you here in the United States. And let me share my screen. Please confirm that you're seeing my screen and that you're hearing me okay?
We can't see your screen yet, Sergio. It's coming up, I think, but yeah, it's come up right now.
Perfect.
We can hear you clearly.
Mm-hmm.
Yes, we can see it clearly right now.
Okay, so one, I want to thank the iNDUS Society for the kind invitation for joining you tonight. And I hope that over the next 25 minutes, I'll give you an overview of how myeloma is currently being managed and the perspectives, particularly in countries with limited resources. These are my disclosures, and my biggest conflict of interest is I am a transplanter.
So Sergio, could you make it into a full screen?
It should be full. It's full screen on my computer.
Okay, sounds good. Thank you.
Is it full screen on yours?
Yeah, it's okay. It's fine, Sergio. It's all right.
Okay. So let's talk about MJ. She's a 42-year-old female who on a routine physical was found to have a white count of 3,300, a hemoglobin of 10, a creatinine of 1, an albumin of 3.2, and an elevated total protein. She's referred to a hematologist who further works up her anemia, the low ferritin, but sends an SPEP which shows an IgG kappa of 4.2 grams with a monoclonal peak of that level. 24-hour urine was normal, beta-2M was 2.6, bone marrow shows 60% plasma cells, low iron stores at her bone survey just shows osteopenia. So I want to remind everybody that I think some of the things that are happening in myeloma, particularly the workup, are important, and I think we need to move with the times. MJ got a bone survey. We feel that bone surveys currently are not the best way to monitor bone disease or evaluate bone disease in myeloma. That whole body radiologic imaging, such as whole body low dose CT scan or whole body MRIs, or PET CTs are probably more appropriate. The most important test besides the history physical and the baseline chemistries is the bone marrow. And in the bone marrow, we need to assess whether there's presence or absence of high-risk cytogenetics abnormalities, particularly deletion 17, 11, 14, 14, 16, 14, 20, and 1q21 amplifications. It's important to recognize that 10 years ago, when actually an MJ was a patient I saw a little bit more than 10 years ago, she actually, would not have been treated because she had no CRAB criteria. This has changed since 2013 when it was shown that patients who have either more than 60% plasma cells in the bone marrow, have involved over uninvolved free light chains greater than 100, or have more than one focal lesion on the MRI, have a very high risk of developing CRAB criteria over the next 2 years, and therefore should be considered as having active myeloma and be treated as such. And when we say treated as such, we made induction, consolidation, and maintenance. MJ decided to opt for iron supplementation and observation, and as would expected, her MP increased, her hemoglobin decreased, and now she has new lytic lesions. So the question that comes up at this time is, what is the best induction for MJ? 2 agents versus 3 agents, and now actually versus 4 agents. And what class of drugs should we use? And as I remind my students, the goals of treatment of all of us is to give our patients the longest life with the best quality of life with the least amount of treatment needed. So in myeloma, obtaining that goal really depends on depth of response. In this slide, this is a very old slide, you can start seeing the impact that achieving a complete remission by standard criteria has on overall survival. And a complete remission by IFE negativity and immune fixation negativity actually has a significant improvement over overall survival when compared to a very good partial response, which is a 90% reduction in tumor burden. So this is of a larger data set for patients that have been followed for more than 10 years. This is a large data set, more than 7,000 patients. So it's not only important to achieve a complete remission, but to achieve a complete remission within 1 year. And I'll pause here again to make sure that technically I'm being heard correctly and the slides are being seen.
Perfect.
Okay. We now have even more sensitive ways to assess the myeloma burden in a patient. A stringent CR, which is currently the most commonly used definition of a very good response, still means that there is a significant amount of myeloma burden within a patient. We know this because when we do next generation sequencing and we do multi-parameter flow, we see a significant amount of patients that have measurable residual disease using these very sensitive parameters. But I also remind everybody that MRD negativity does not mean zero myeloma cells. MRD negativity just means that a patient has either 1 in 100,000 myeloma cells or 1 in a million, 1 myeloma cell in a million normal cells. And that it is possible, and people actually do relapse after MRD negativity. But should MRD negativity become a surrogate outcome? The data starts suggesting that yes, that patients who achieve an MRD negative status during their initial treatment have significant better outcomes. We also know, based on data from the relapse refractory setting, that patients who achieve MRD negativity also have better outcomes in regards to progression-free survival and overall survival. So let's get back to our patient. What should we give? Induction, consolidation, maintenance. And what induction should we give in all the different kinds of drugs we have? Immune modulators, proteasome inhibitors, steroids, alkylating agents, anthracyclines, monoclonal antibodies. So what should we consider when planning induction therapy for myeloma? Well, the basic principles are it has to be effective, it should be tolerable, it should preserve stem cells, and it should be available. Clinical factors that I think are important to consider is that a patient with inadequate renal function, the use of lenalidomide or IMiDs is extremely difficult because of severe cytopenias. And thus, a combination of cyclophosphamide, bortezomib, and dexamethasone is commonly used as a first cycle, particularly if lenalidomide is not available. For our older patients or our diabetic patients, we definitely should reduce the steroid dose. In patients with bleeding or clotting disorders, the use of IMiD needs to be seriously reconsidered because of the need for anticoagulation and the increased risk of clotting that happens with these agents. Obviously, in a patient with prior neuropathy, the use of bortezomib would be something that we might want to avoid. And there is more and more opinion, because we still do not have data, that for patients with high-risk features, carfilzomib or daratumumab, the CD38 monoclonal antibody, should be included. So what do the randomized trials show us? And I think one of the things that should be laid to rest is that all randomized trials have shown that triple therapy induction is superior than double therapy induction. This is the SWOG 2015 trial comparing bortezomib, lenalidomide, dexamethasone to lenalidomide, dexamethasone. Not only better progression-free survival, but significantly better overall survival. So if we are going to do triple therapy with an IMiD and a proteasome inhibitor, or if we're using it as a backbone a proteasome inhibitor, which is the best partner for the proteasome inhibitor? And what it would seem today in most of the studies in which a proteasome inhibitor has been combined with either an IMiD or an alkylating agent, the combination of bortezomib, thalidomide, dexamethasone has been. Should I be worried that if I'm giving a patient bortezomib, cyclophosphamide, dexamethasone instead of bortezomib, lenalidomide, dexamethasone? The answer is probably not. This is real-world data from the CIBMTR that yes, the outcomes seem to be somewhat inferior for bortezomib, Cytoxan, dexamethasone, but remember that these patients, many of them have renal dysfunction, so they may be significantly inferior. So as long as you're taking these patients to transplant and then giving them some form of maintenance therapy, the induction therapy using these traditional triplets becomes less important. But what do the modern randomized trials tell us? So this is the Forte trial recently presented at ASCO by Dr. Francesca Gay, looking at the question of, with the novel proteasome inhibitor carfilzomib in combination with lenalidomide, dexamethasone, what is the role of high-dose melphalan consolidation? And what is the best partner for this proteasome inhibitor, either the alkylating agent or the immune modulator drug? So again, this was a 3-arm randomized trial. One group got carfilzomib, lenalidomide, dexamethasone for 12 cycles without getting high-dose melphalan consolidation. The second group got 4 cycles of induction with carfilzomib, lenalidomide, dexamethasone, consolidated with a single auto transplant, and then followed by 4 more cycles of carfilzomib, lenalidomide, dexamethasone. And the final group received 4 cycles of carfilzomib, Cytoxan, dexamethasone on auto transplant, followed by 4 cycles of consolidation with the same induction. I'm not going to go into the results of the carfilzomib, Cytoxan, dexamethasone group, which was inferior, but I want to focus on the results of the patients that received consolidation with high-dose melphalan or not. Although the overall response rate seemed to be similar in overall patients, for patients with ISS stage 1, there seemed to be a better response rate for patients who got high-dose melphalan consolidation, but for patients with ISS stage 2 and 3, the response rates were similar. However, for patients who received high-dose melphalan consolidation, the risk of early relapse was significantly less than for patients who just received carfilzomib, lenalidomide, dexamethasone. Once again, suggesting that high-dose melphalan autologous transplant deepened the responses and eliminated potential clones that were resistant to the induction therapy being received. And this is the multivariate analysis, again, showing that 1, MRD negativity is important, 2, high-dose melphalan reduces the risk of relapse, and obviously ISS stage remains a very important prognostic factor for overall outcome. This presentation by our friend Sajid Kumar was a surprise in ASCO 2020 this year. Here, the combination of carfilzomib, lenalidomide, dexamethasone was compared head-to-head with the combination of bortezomib, lenalidomide, dexamethasone in newly diagnosed multiple myeloma patients. I remind you that most of the patients in this study had standard risk disease and very few patients had high-risk disease. This is the design standard bortezomib, lenalidomide, dexamethasone versus the carfilzomib, lenalidomide, dexamethasone as the standard dose of 20 milligrams per meter squared on day 1 and 2, and then the next cycle with 36 milligrams per meter squared for days 1, 2, 8, 9, 15, 16. Lenalidomide 25 milligrams and dexamethasone is the dose you see there. To everybody's surprise, progression-free survival was the same for patients receiving RVD versus KRD. And that was a surprise for everybody. And with censoring at stem cell transplant alternative therapy, the median progression-free survival for RVD was 31 months and for KRD was 32 months. Again, no statistically significant difference. And again, there's no overall survival difference seen at the time of the report, although this may have been too early. But with that progression-free survival difference, it's unlikely that we will ever see a survival difference. Does this mean that KRD should not be further explored? No, we think KRD can continue to be explored as a backbone, particularly for patients with high-risk disease. So if 2 drugs is better than 3, 4 drugs better maybe, if 3 drugs is better than 2, 4 drugs may be better than 3. This is being explored and was published by Dr. Philippe Moreau in the Cassiopeia trial, where he compared the standard backbone of VTD to VTD addition to the CD38 monoclonal antibody daratumumab. After 4 cycles of VTD daratumumab, patients would undergo high-dose melphalan consolidation and then receive 2 more cycles of consolidation with the same schedule they received as induction. This was, the first report was the comparison of arm A and arm B before maintenance therapy. And as you can see, the addition of daratumumab to the standard backbone of VTD significantly increased the major responses as defined by stringent CR, both before the transplant, after the transplant, and at the time of best response. So this showed a significant benefit in regards to response rate with very acceptable toxicities. This resulted in a significant improvement in progression-free survival at 2 years for the daratumumab-containing regimen with a p-value of with a hazard rate of 0.47. Interestingly enough, at this time, and again, I think some of this is because the follow-up is not long enough, the patients who achieve a stringent CR with VTD did as well as patients who achieved the stringent CR with Dara-VTD. But I think some of this data will change as follow-up goes longer. All subgroups of patients seems to be benefit by the addition of daratumumab to VTD. So again, this is the first randomized trial suggesting that addition of the monoclonal antibody to the standard platform of a triplet may increase outcomes may improve outcomes even further. This is the Griffins trial, again, studying instead now of VTD, looking at a standard North American regimen of RVD, Dara-RVD for 4 cycles, followed by transplant, followed by Dara-RVD compared to RVD. And again, as we saw in the Cassiopeia trial, significant improvement in stringent CRs, 42% versus 32%. At the time of post-consolidation and best response, 51% of the patients had a CR or greater, 90% of the patients had a greater than a VGPR, significantly better than what was seen in the group of patients that did not have the monoclonal antibody, 32% of patients with stringent CR and 42% of the patients greater than CR. And this translated into significant improvements in MRD negative CRs, 28% versus 9%, and 47% versus 18%. Did daratumumab affect collection? It did not affect stem cell collections. However, we have seen that when patients get more than 4 cycles of daratumumab, particularly in combination with carfilzomib, stem cell yields decrease significantly, and therefore we are recommending that patients get collected after 4 cycles. What happened with our patient? MJ received 4 cycles of RVD, had stem cells collected. She had doubts about proceeding to stem cell transplant. And I think when a patient reflects those doubts, it's important to remind them of the paper that was recently published by Dr. Cabell, showing again in patients randomized to transplant versus early transplant versus delayed transplant, significant benefit in progression-free survival for early transplant. More importantly, for patients with high risk, significant survival benefit. And the survival benefit that's not only statistically significant, but clinically meaningful. 74% of patients alive at 3 years versus only 50% for patients of early versus late. So delaying transplant may have negative consequences for patients with high-risk disease as defined by 414 translocation, 1416 translocation, abnormalities of chromosome 17 or RISS stage 3. Despite this data, and I think across the world, we've been impressed of the underutilization of transplant. This is data for the United States, where only 50% of Caucasians and 25% of African Americans are actually getting transplanted. What's the role of maintenance therapy? And again, in the context of 3 randomized trials, maintenance lenalidomide should be considered standard of care, significant improvement in overall survival when we do the meta-analysis. Yes, there is an increased risk of second primary malignancies. This actually may be mitigated by using syncopated lenalidomide 21 out of 28 days. And what's the role of measurable residual disease? At this time, my main use for measurable residual disease is to encourage patients to continue on lenalidomide maintenance. Lenalidomide maintenance, particularly for patients after 2 or 3 years, is associated with significant fatigue, some diarrhea, and some rash, and many patients want to come off the drug. This is the French data suggesting that patients who after 2 years of lenalidomide maintenance of MRD negative, their risk of relapse once they stop the drug is about 20%. However, if they're MRD positive, their risk of relapse is 80% over the next 2 years. And I use this slide and this data to encourage my patients to continue lenalidomide, or if they're patients with low-risk disease and MRD negative, to give them a drug-free period. Luciano Costa has taken this to the next level with the master study, where he's actually using MRD to decide to stop treatment at a specific time points. This is the first presentation, and we are looking to see long-term follow-up this data in the future. So what happens if MJ relapses? There's a lot of things that we can do. There are monoclonal antibodies, there are new proteasome inhibitors. How the treatment of relapse now has become, I would say, a challenging thing. A lot of it depends on how the patient responded, whether they're transplant naive or not transplant naive. This is just a meta-analysis of all the salvage studies done. The bottom line here is, I think, a DARA-based salvage regimen is probably the most effective way of re-inducing remission. In patients who've had a long remission after an initial transplant, a second transplant will deepen the response, and a randomized trial from Germany suggests that it may improve outcomes. I want to finish with CAR T cells, as Hari did. This was presented at ASCO this year by Nikhil Munshi. This is the trial that will hopefully lead to approval of ide-cel for patients with refractory relapsed myeloma. This is the design of the trial, greater than 3 prior regimens, penta-exposed, triple refractory, as we say. This was a dose escalation. Again, very high response rates for patients getting more than 150 million flat cells, BCMA CAR T cells, and with CR rates of anywhere between 30 to 40%. Response is seen in all subgroups. However, the median duration of response is around 9 months. Obviously, with patients having CR and stringent CRs, having responses that now seem to be lasting for more than a year. So depth of response in patients getting CAR T cell is also important, but these curves are far from stable, and there seems to be, as opposed to lymphoma curves, a continued risk of relapse. Toxicity is the same as with the lymphoma products, CRS, most of them grade 1 and 2. About 40% of the patients, particularly at the higher dose, 60% of the patients will require tocilizumab, and 20% will require steroids. Neurotoxicity, again, no grade 4 neurotoxicity, about 5 to 6% of the patients having grade 3 neurotoxicity. And the other adverse effects are primarily cytopenias, most of them reversible. I want to finish by reminding people, again, we think allotransplant has a role here. It's the only known curative option for patients with multiply relapsed disease. But when you leave it to the last option, it generally does not work. So I think one of the challenges for the future is decide where do we think allotransplant should fit, particularly for young patients with multiply relapsed disease? So in conclusion, the diagnosis, workup, and treatment of myeloma has changed over the last 10 years. The therapeutic goal is to obtain deep remissions that can translate into improved PFS and OS. With combination therapy of IMiDs, PIs, antibodies, transplant, and CAR T cells, long-term disease controls and cures should be achievable in a substantial proportion of patients. Thank you very much for your attention.
Thanks very much, Dr. Gerald, for your outstanding presentation and staying on time. Before we go on to the audience discussion, I do have an announcement to make, so bear with me for a moment. I just wanted to remind the audience that the next INDUS BMT webinar would be on 12th of September, so a week later than we normally do because of the holiday in the US in the first week of September on Saturday. And this is going to cover hemoglobinopathies topic, and we have two outstanding speakers for that session. Dr. Shalini Shenoy, who is professor of pediatrics at St. Louis Children's Hospital, St. Louis in US, will be providing information on clinical aspects of thalassemia and sickle cell disease, including results of transplantation. This will be followed by a presentation from Dr. Poonam Malik, who is a leading expert in gene therapy for hemoglobinopathies. She's from Cincinnati Children's Hospital. So please hold the date and hope to see you all for the next webinar. Thanks very much. And with that, I would like to have Dr. Pankaj Malhotra and Dr. Sharad Damodar take over for the question and answer session. I can see that on the scroll, there are a number of questions. So some of them have been answered already in the chat box, but perhaps we can cover those and others.
Thank you, Dr. Rakesh. If I may start with questions directed to Dr. Hari on topics of lymphoma. So there are a few questions related to CAR T cell therapy, starting with the first one being the cost of it and its relevance to our country with the current costs. Dr. Hari?
Thank you, Dr. Damodar. CAR Ts are very expensive. If you think about the cost in America, the acquisition cost for the agent itself, if you buy it from a commercial company, it's in the order of $400,000. That's a lot of money. And most patients so far have actually been treated on trial, so we haven't actually felt the pinch here. In our center, we have a program of making CAR T cells from the patient in a near patient manufacturing system using the Prodigy machine. This data is accepted for publication. It'll be coming out within the next few weeks, which is highly successful. We used a dual targeted CD19-20 targeting, all that. So if you have ability to do that, that can be done very cheaply. All you need is to buy the vector and the reagents, and that can bring down the cost dramatically. And many other countries are thinking about that kind of approach, which I think is the way that a society should go if we cannot afford these $400,000 drugs. It's for a single patient for a 50% overall survival. Even if you assume a 50% cure, that's a huge burden on most societies.
Yeah, thank you, Dr. Hari. So I think there are 2-3 centers in India who are actually looking at starting CAR T cell based therapy and obviously trying to cut the cost and bring it somewhere in the 50 lakh range, which is about $60,000-$70,000 US, which is kind of affordable to a subset of patients. Right. And thereby, I'm sure that it will come up in the algorithm of management. Now, on the same thought, there are 2-3 questions which are related to, you brought up the issue of, if you've had prior exposure to Ritux, which is the standard of care now when you give R-CHOP, and then you relapse within a year, the outcome even with the auto is really bad. So in that situation, how would you position the role of auto? Would you look at a potential allo to back that up, or will you bring in CAR T in that situation?
So if you analyze the people who are early relapsers with R-based chemotherapies, R-based R-CHOP or R-EPOCH, etc., the the patients who actually make it to auto do tend to be okay. So, but the vast majority don't make it to auto. That is where the failure happens, because salvage is very ineffective, and you don't have people with sensitive disease in that population. So the people who are relapsing, they don't have sensitive disease. They either have a primary refractory to salvage disease, or they are rapidly progressing, or they have residual PET positivity. So many reasons why auto will not work in that population. But the people who actually get to auto, despite the early relapse, they do very well. So if you should still do salvage, is my opinion, and you will identify that subset of patients who can go to auto in that population. If they get to auto, their actual survival is actually very close to that of patients who cannot get to auto. But in that other group, that is the population where I think the CAR-T versus auto trials are going to show a difference, because at least 2 of those trials, you relapse, the first thing you do is collect pherese for CAR-T. Unlike, do salvage, then collect for auto, you can pherese the patient at that point before they get more lympholytic therapy. If you get more lympholytic therapy, you may not even have enough T cells to collect, and you may have a manufacturing failure for CAR-T. So that's an area where CAR-T will immediately slot in, because then suddenly that disease becomes much more amenable to a cure. Even a CAR-T-based cure, or if they are in a PR after CAR-T, I think they should go for an allo. So I think we have to come up with a better CAR-T becomes the first salvage for this early relapse. The progressors on R-CHOP, the people who have a very, very short interval after R-CHOP or R-EPOCH, and especially these double hit and triple hit lymphomas, where we are actually not expecting chemotherapy to cure almost anybody. So those patients definitely, I think that's where CAR-T has its best role. We should not also forget, there is, bispecifics, the CD20 bispecific that was presented at ASH had a really, really good outcome. So those are other agents that will come in that area. And then the CD19 ADCT, which is a molecule with CD19 conjugated with a payload, a chemo payload. So basically antibody drug conjugate. That also will be. So we will have, outside of CAR-T, we'll have 2 other agents, CD20 bispecific agent and a CD19 antibody drug conjugate. So we have a little bit better salvage. So that population where the people are failing quite dramatically these days will shrink.
Okay, I have 2 more questions, Hari, before we move on to the myeloma, and I'll hand it over to Pankaj. So one is there a B-cell aplasia described post-CAR T-cell therapy?
Right. So there are a couple of different, actually, there was a slide in my slide set which I actually went through quickly or did not even talk about, that there are 2 events. One is that acutely after CAR-T, when people are getting CRS, there is a small group of patients who get hemophagocytosis or, HLH-like syndrome. So that's a myeloma that happens, and that needs to be treated with steroids like we do. And that is an extreme marrow stress event, and that people have to be on the watch out for that. We monitor ferritin and CRP and all that. So that's, again, we are all very good at managing that, but unless you look for it, you won't find it. That's why I'm mentioning that. The question really asks about the long-term B-cell aplasia, which, initially we thought all these patients are going to be permanently on IVIG for life. In real life, we are not seeing that. Even in the BCMA CAR-T, we are not seeing that. So what happens is people run a low hypogammaglobulinemic situation. That is true. About 60% of the patients that we have treated with B-cell targeted CAR-T, CD19, are actually hypogammaglobulinemic, defined as less than 400 IgG level. And initially, I used to transplant, everybody got IVIG, but IVIG is being increasingly denied by insurance in this country, and there's a shortage of IVIG. So now I give it very infrequently, every 6 weeks or 8 weeks like that, and we are managing with very few infections. Sergio has probably more experience with this, but I'm seeing that and over time, their IgG levels are actually coming up.
And I think the guidelines are coming out that it's the same CLL guidelines, that patients should be treated only if they have recurrent pulmonary infections and not just because of the number. Yeah.
Right. One question on mantle cell lymphoma. So if you had mantle cell lymphoma with the TP53 mutation, how would you kind of go about planning the treatment for this patient?
So that's a very, very difficult question and a tough thing. So again, TP53 mutation in mantle is a little bit like myeloma in that there are 2 or 3 aspects of the P53 mutation we need to consider. Some people have a subclonal mutation. So there is a big mantle clone, and the P53 is a small subclonal population. Those people should get chemoimmunotherapy and should be treated normally. But the people who do really, really poorly are the other people who have a clonal TP53 mutation, and especially people who have what we call biallelic P53 deletion, which means they don't have any P53 gene product. The protein is no longer present in their nucleus. So the cells really cannot undergo apoptosis. So these people are guaranteed to fail chemoimmunotherapy. For us, if we have the subset of patients in that group, which is a small single-digit percentage, we are actually thinking about using venetoclax upfront to get a response, and then consider allo transplant or Carpi as the first treatment. So most of them are primary refractory. They have residual disease. They don't get into CRs, and you can actually justify doing those things.
Right. Thank you, Hari. I'll now hand over to Pankaj to direct the myeloma questions, and then if there's time, we'll come back to you again.
Yes,
Pankaj?
thank you. Yeah, thank you, Sharad, and thank you, Dr. Chiralt, for giving an overview of myeloma, how from 2-drug combination therapy in induction we have gone to 3-drug and possibly going on to the 4-drug induction therapy. And here what the confusion comes, that possibly we are at a stage where we are transiting from 3-drug induction to 4-drug induction. So the question which are asked are whether the major problem in myeloma we face is the high risk myeloma. So whether it is 17p or the other. So what do you feel that in the current scenario with the available data, should we go for 3-drug induction or for DARA-based 4-drug induction?
So that's an interesting question, and I think one that I'm going to answer in 2 parts. One is, if in the United States, for example, where you can think that you have access to all these drugs, the data is starting to emerge that 4-drug inductions may produce deeper responses across all risk categories, that they're really, all risk categories benefit from this. And therefore, you can think about a patient with stage 1 disease, you do a 4-drug induction, that patient achieves an MRD negativity, and then you have to ask yourself the question, should I expose this patient to high-dose melphalan, or should I just continue with some form of mitigated or lower dose strategy, monitor them, and just take them to high-dose melphalan autologous transplant in the event of a relapse? You can also say, well, maybe these are the patients we should cure, we should transplant them all. Those are the types of questions that we're going to have to answer in the future. In countries with less resources, you're going to say, look, we can't do that because we just can't afford giving everybody KRD-DARA. We will have to limit it to the people who are truly high-risk disease, ISS stage 2, ISS stage 3, or people with high-risk cytogenetics. Everybody else will give a standard RVD, and only those who fail to achieve an MRD negative CR will we consider to escalate to add another class of agent as part of the post-maintenance therapy after transplant. I really view that there is a large proportion of patients, ISS stage 1, ISS stage 2, standard risk disease, that the results with RVD, high-dose melphalan, and then post-transplant lenalidomide are extremely good. And if those patients are MRD negative at the 1-year mark, the data that I haven't shown from Stamina and from the primer study suggests that they are likely to stay in remission for the next couple of years. We need to also remind ourselves that there will be new technologies for us to monitor patients with myeloma beyond SPECT. Mass spectrometry monitoring of paraprotein peaks, still not ready for prime time, but it's already been published. This may be ways that we can actually monitor tumor burden to a level of 10 to the minus 4, 10 to the minus 5, without having to do a bone marrow and monitor MRD with bone marrow.
Yeah, thank you so much. You are absolutely right that in resource-constrained setting, like in India, a 3-drug induction is possibly good for standard risk patient. So here, the question which is asked is, where do you place 1Q amplification in the standard risk or in the high risk? Because what we see in resource-constrained setting is that most of the patients, they present in a late stage. So almost, when we do the FISH cytogenetics in them, we see a lot of patients, almost 40 to 50% have 1Q amplification. So what do you suggest a therapy, induction therapy and post induction therapy in them?
So unfortunately, it's like in Latin America as in India, most of our patients are presenting with advanced disease. 1q amplification is a poor prognostic factor. ISS stage 3 is probably the worst prognostic factors of all. And then response to primary therapy is another very important prognostic factor. So I think in resource-constrained countries, you really are going to have to do, I would say, a response-assessed therapeutic algorithm. So everybody gets triple therapy, high-dose melphalan, autologous transplant, and then at the 3-month mark, depending on what the response has been, you decide whether there are going to be multiple drug consolidation, adding the monoclonal antibody. When you have CAR T cells, those are the group of patients you might think. The one advantage with CAR T cells that we're hoping will come true is that you will get in the frontline setting deep responses that will require no further therapy. And that period of time that you are drug-free is actually a period of time that you can recoup the investment you made with all the expensive drugs up front. But that remains to be proven.
All right. Thank you. One of the question which is asked is that many patients actually present with lymphadenopathy, and they are not plasmablastic lymphoma, they are myeloma. And and sometimes they do not respond to triple therapy. So what is your strategy to treat this kind of a rare myeloma patients?
So it's interesting, Dr. Bart-Balaji had always said that patients who presented with this type of lymphadenopathy, particularly with a high LDH, many of these patients would respond to multiple alkylator or multiple agent chemotherapy, such as VDT paste-like regimens. So for many of these patients, particularly with high LDH, triple inductions, we will mobilize them with 1 or 2 cycles of VDT paste, give them high-dose melphalan, and then give them combined therapy as maintenance. They are generally very poor prognosis.
All right, thank you. So as you already said, and this is the practice in India also, that all patients are receiving 3-drug combination therapy, IMiDs with proteasome inhibitors and dexamethasone. Now the question is that if these patients relapse, then what do you do with these patients? You mentioned about using daratumumab in these patients, but what else do you suggest to in these patients?
So Pankaj, before I answer that, Santosh had asked in the Q&A about the reference for underutilization of transplant. It's a paper of Luciano Costa, C-O-S-T-A. You can look it up, and if you don't find it, send me an email and I'll forward it to you. So I think the treatment of myeloma relapse at this time is really now challenging, and one where expertise in myeloma is essential, or looking for a second opinion with somebody who's had expertise in myeloma is always helpful for patients. It obviously depends on the patient's performance status, how they responded and tolerated prior therapy, and the efficacy of the prior therapy. But, so you can imagine that a patient who's had RVD, melphalan, and is relapsing on lenalidomide maintenance 5 years down the road is a patient that you can think about doing the same thing. RVD, second transplant, another type of maintenance with now a different proteasome, with a different maintenance strategy, either pomalidomide or a proteasome inhibitor. More challenging is the patient that now has had multiply relapse. Now, all of us have had the experience of recirculating drugs in myeloma, that we think a patient who's been exposed to lenalidomide in combination with a proteasome inhibitor, when they come back, you can still get the response to lenalidomide if you combine it with an alkylating agent or if you combine it with a monoclonal antibody. Obviously, the best strategy is to try to put these patients on a clinical trial. I think the core questions I always ask myself is, 1, is this a young patient with multiply relapsed disease that I have a chance of getting long-term disease control with an allo? And I try to if you wait to do an allo 5 lines down the road, that patient's not going to respond. But if you do an allo within 1 to 3 prior treatments in a young patient with multiply relapsed disease, you probably can make a significant difference in their long-term outcome. The second question I ask myself is, do I have cells in the freezer? And it's really important to always remember, particularly if it's a patient that you don't know, is to ask them, do you have cells collected somewhere? Because you want to be able to utilize those cells for something. Sometimes we utilize those cells to qualify a patient for the protocol. Sometimes we use for a second autologous transplant. Who benefits from a second autologous transplant? Patients who have had a long remission, and actually patients who are refractory to, who really are refractory. You can get patients to respond to high-dose melphalan, and those responses can serve as a bridge to some other treatment. So I do think, the treatment of patients relapsing with relapsed myeloma now is challenging. You have to have a good understanding of what that patient's received previously and what and how they tolerated it.
Yes, thank you. I think that's very important remark that you have made, that a young patient who is relapsing multiple times, it's better to push allogenic upfront rather than waiting too long in that patient. So similar question is for 17P, that what is your strategy in young patient of 17P? Do you go ahead with the tandem auto, or do you want to go ahead with an allo transplant?
So that is a long conversation with the patient. If you have a 45-year-old patient who presents with stage 3 myeloma and abnormalities of chromosome 17, to tell that patient, oh, with therapy, I can give you 5 or 6 years, he's 45. So that patient is a patient where the chance of cure has to be discussed. And particularly, I think, an allo transplant in the context of a clinical trial. We recently published the long-term outcomes of both tandem autos and reduced intensity allo in the BMT 0102. And we showed that there was a benefit for auto allo in patients with high-risk disease who received an allogeneic transplant as consolidation of autologous transplant up front. There's similar data that Luciano Costa put together in a meta-analysis of all the biologically assigned trials, suggesting the same benefit for patients with high-risk disease who received allogeneic up front. And I think at this time, we have to remember everybody has a donor. Our expectation is that patients who receive the haplotransplant and post-transplant side will have similar outcomes than if they received the match-related donor with myeloma. And I'm glad that I answered Dr. Popat's question.
Yeah, I think that answers Dr. Uday Popat as well as Dr. Rakesh Goel questions. So thank you. Coming back to the MRD, you did mention in your slides that achieving a stringent complete response within an year of treatment, these patients have a good long-term outcome. So what about the MRD now? So at what stage the patient should be MRD negative? Post-induction 4 to 6 cycles, post-transplant, post-maintenance. So where do you place MRD at what point of time?
So it's interesting, and Harry will comment a little bit about this too. We just finished analyzing the primer study, which was a secondary analysis of this data from the randomized trial of tandem auto versus auto plus consolidation versus auto and just single agent lenalidomide maintenance. The stamina trial, in which there was no benefit so there was no difference in outcomes for patients who received tandem auto versus auto plus consolidation versus just going straight to lenalidomide. What we did see, however, that at the 1-year mark, achieving MRD or being MRD negative 1 year post-transplant had a significant benefit in overall outcome. And the highest proportion of patients who were MRD negative were actually those patients who had received the tandem transplant. Now, there are a lot of problems with the way the stamina trial was done that makes it difficult to make the recommendation that we should re-explore tandem transplants. We think that in patients with high-risk disease, this is a question that needs to be addressed, but definitely MRD negative at 1 year seems to make a difference. What we don't know, and this is important, we don't know if somebody who's if I convert somebody who's at 6 months MRD positive, if I can convert them to MRD negative, does that make a difference? And there's actually a series of trials using CAR T cells and using other agents trying to address the question that if you have somebody who's stable MRD positive and you convert them to MRD negative with an intervention, have you changed the natural history of that patient?
Yeah, thank you. So Sharad, do you have more question, or should I continue with myeloma?
I'll just ask 2 questions to Hari because they've just popped up. I think Hari was eager to answer this on the role of haplotransplants in both Hodgkin's and non-Hodgkin's. Hari?
Yeah, so haplo, the question was about haplo in lymphoma, myeloma, etc. So we don't have any randomized trials or anything, obviously, as everyone knows. But we did 2 large CIBM analysis, one in NHL and one in HL. And in both, there was lower chronic GVHD, lower acute GVHD, less non-relapse mortality, and similar overall survival for haplo in NHL. In Hodgkin lymphoma, there was also a suggestion that the haplo patients had slightly lower risk of relapse. So there is, if you look at it, it's about hundreds of patients in these analyses, and actually it's really, really good data for doing haplo. So I have really, and these are all haplos done in the PostSci platform. So really, that's excellent data. In fact, for many patients with Hodgkin's, that's one of the things that I think about upfront. We do very little Hodgkin's allos now because of PD checkpoint inhibitors and brentuximab, etc. For myeloma, we have again, one thing we have proven is that with haplos in myeloma, the non-relapse mortality has gone down dramatically. But the sad part about haplo in myeloma is that it is, just as Sergio said, almost all of that is done way, way, way late after patients has had 3 or 4 relapses. At that point, the haplos just gives you a little bit of time, in a few months, because patients are going to relapse. Relapse is our biggest risk. In haplo in myeloma, compared to the other platforms, the NRM is significantly lower. These are all reduced intensity haplos, post-Cy, but you really have to have a follow-up plan. So when we do it, it is mainly for our African American patients, and I have a lot of people who we have done haplos on in the first relapse or second relapse, who then have an agent to go back to. At that time, DARA was a new drug. Most of them were DARA sensitive. We would put them back on DARA as maintenance, and many of those patients are now 5 and 6 years out without any problems.
Okay, one more question, Hari. What are the options for somebody who relapses post-CAR T-cell therapy?
So post-CAR T-cell relapses are primarily, we think, from 3 reasons. One is that antigen, loss of antigen. So CD19 can go away, BCMA can disappear. Second is T-cell exhaustion, senescence, and disappearance. So T-cells have an AUC, they tend to go down with time. And sometimes they are senescent or exhausted. They don't spike back up when the antigen starts reappearing as the tumor grows back. And finally, the third group is there is something wrong with the microenvironment. So this microenvironment type problems, you can actually, many people have done additional agents to stimulate the T cells. Classic would be a checkpoint blocker. So there's a lot of trials and a lot of anecdotal data that you could do that for people who are relapsing in a very slow, not a clear-cut explosive relapse, but a slow relapse. And you can actually buy some time that way. However, again, if the patient has not had an auto transplant in the first round for a lymphoma, they have a CAR T and then they're failing, you really definitely should be considering an auto transplant at that point, because that is still standard of care and we really should not abandon it. My bias for younger patients would be to think about an allo, and especially with the reduction in NRM these days. So younger patients, I would certainly think about an allo for those patients with some salvage before, and for older patients, probably even just doing auto.
Thank you, Hari. Pankaj, back to you if you have any more questions.
Yeah. Thank you, Sharad. Yeah. So can we discuss something about the carfilzomib? The good point is that generic carfilzomib is available in India, and there are a couple of questions on carfilzomib. Now, people are disappointed with the results of VRD versus KRD. So there were a lot of hope that KRD would be winner, but it has come as equal. But then obviously the question is that the high-risk patients were not included in the trial. So what is your opinion in the high-risk myeloma patients? Do you think that the KRD upfront would be a winner, or should we wait for more results?
So I remember these are drugs, they're not horses, so there's no, the winners should be our patients, and we should just, the data is the data. If I had a high-risk patient now, I would try to put them on a study where they would get a 4-drug induction. some form of high-dose consolidation, and some form of novel post-transplant consolidation with some form of cellular therapy. As Harry mentioned, there will be BiTEs for myeloma. There will be CAR T cells for myeloma. I do think we need to incorporate those into our algorithms for the high-risk patients, particularly for patients, for patients less than 80 years of age. I mean, we really should be the myeloma field should be proud of the success it has had of tripling the expected survival. But I do think that our challenge for the next years to come is to how can we do this in a way that's sustainable and that actually affordable. And I actually think that a lot of our resource-constrained colleagues will actually teach us how to do this in a way that will be financially responsible.
Yeah, so maybe I should go a little bit more specific. Do you think the dose of carfilzomib makes the difference whether you use 36 mg per meter square or 56 or 70, once weekly, twice weekly? So can you make some comments on the dose?
I currently do 56 milligram per meter squared weekly, 3 weeks on, 1 week off. I've had, particularly with older patients, with 70 milligram per meter squared, you get into trouble very quickly. I don't do carfilzomib as a AA. I do it as a triple with either, when you're doing it in the salvage setting, you're usually doing carpom dex. So you're doing it in combinations with other agents. We have an interesting study we're doing with Harry called the Second Chance Study, where we're doing KRD Dara for 4 cycles, a second transplant, and then another KRD Dara for 4 cycles. We're getting very high response rates. We're now trying to see what the maintenance for those patients are. This is in the setting of patients who failed 1 to 3 lines of therapy. So I think to your question is, carfilzomib, what dose? I would say 56 milligram per meter squared weekly is what I use the most. In combination with what? I think, in a patient who has failed an IMiD, you probably should combine it with an alkylating agent, although we've seen patients who are failing lenalidomide have dramatic responses to carpom dex. CAR-Dara dex is an extremely active regimen, and I think if you can add another drug, it also works better.
Thank you. I think there is a signal coming up for wrapping up the discussion. So over to the Dr. Goyal.
Thanks very much to the speakers, the participants, and the audience for this lively and very instructive session. See you again in September. And I would like to have the stage to Dr. Matthews for his concluding remarks. You're on mute.
So I'm sorry. I want to thank Indus BMT and the speakers. Thank you so much, Hari and Sergio, for taking the time and doing this and providing us an excellent overview on the topics. Thank you so much once again.
It was a true pleasure. Very enjoyable.
To all the participants and the chairpersons who conducted the questions, Sharad and Pankaj, thank you for coming on, and to all the participants. And finally, I want to thank MCure for facilitating this meeting. Thank you. And I will hand over to Arvind for the last few words, and we'll close out. And as Rakesh said, hope to see you in September and continue to participate in our webinar series. It's purely an educational platform, and we would love to have feedback on how you think we can improve this platform and this educational platform. Over to you, Arvind, and we'll close with that. Thank you. Arvind?
Yeah. Thank you so much, sir, for your wonderful moderation, and it has been really a stimulating experience to listen to all the presentations and the question and answer session. So on behalf of MCure team, I would like to express my sincere thanks to each one of you and also the audience for joining us today evening and taking your time out. We are also privileged to launch a brand of Thiotepa called as Tepa Pro for your patients for their better patient care. And with this, I conclude that the meeting has been ended, and then have a nice time, and till we meet again in September. Take care, and thank you so much for joining us. Thanks a lot.
Thank you, everyone. Good night and good day to those in the US. Bye.